Good afternoon, and welcome to today's breakout session, Specialty, RX, and Precision Prescribing, sponsored by Fitbit. My name is Amy Swanson, and I am the Health Improvement and Communications Director for Health Action Council. Today, we're happy to have with us Mike Zeglinski and Scott Megill. Mike Zeglinski serves as Senior Vice President at Optum RX and brings more than 30 years of experience in the specialty pharmaceutical and home infusion business. He is responsible for leading the division's strategy, growth, and sales efforts, patient service programs, payer services, and therapy care management services. Scott Megill is President and Chief Executive Office of Coriell Life Sciences, launched out of the renowned Coriell Institute for Medical Research in 2013. Scott is currently spearheading the world's first precision medicine approach to COVID-19 testing. He's been consulting with employers and large organizations to deliver one of the only scalable and intelligent COVID-19 testing solutions for large enterprises in the US and globally. As medications for complex conditions are becoming increasingly expensive and difficult to manage, it is important for employers to understand blind spots in their pharmacy plans. This session will review what's trending in specialty pharmacy, in addition to an integrated approach to specialty management across the medical and pharmacy benefit. It will further examine the value of scalable precision medicine and the benefits of pharmacogenetics. Before we begin, I want to remind everyone, if you have questions, please use the chat box located on the right-hand side of your screen. I will be monitoring the chat box, and at the end of today's presentation, we will ask Mike and Scott to answer all of your questions. All sessions will also be recorded and then available on the Conference and Expo platform for the entire 5 weeks. This breakout session is pending for both SHRM and HRCI credits. We'll hold a poll at the end of the session for those attendees who would like to receive credit upon approval. Also, anyone who would like to receive ODI credits, this session is pending approval. In order to receive ODI credits, you must respond to the periodic polling questions that will appear on the right panel under polling. These polling questions will only be visible for a brief period of time, so please respond immediately. You must respond to all polling questions to qualify for ODI credits. With that, Mike, the floor is yours.
Thank you very much for that introduction, Amy, and I'm very happy to be here speaking with you all about specialty pharmacy. As Amy said, I have been in this business of specialty pharmacy prior to whenever it was even a term as a specialty pharmacy product, or what we're all talking about today, where specialty pharmaceuticals are essentially consuming more and more of the cost and spend of payers as we seek to provide these very wonderful medications for a variety of disease states for people who are in great need for chronic conditions, but are coming at a very high price tag. So what I'd like to really speak with you all about today is the value that specialty pharmacy brings and how specialty pharmacy is able to work and integrate from a pharmacy and a medical benefit perspective, as well as working at the specialty pharmacy, and how the services that are provided by a specialty pharmacy can benefit members and also help in order to reduce those costs and what payers are experiencing. So as you see before you, it's vitally important that the specialty pharmacy is part of a connected care team. And in order to do that, the coordination of all of these services that patients need due to their comorbidities and due to other conditions and concerns that they have to be coordinated. So you see that the specialty pharmacist in particular is part of that connected care team. So as I get into what exactly we are looking to do, especially around the integrated specialty pharmacy perspective, it's really important to understand then how we are integrating this specialty pharmacy approach. And that comes about from our ability in order to manage these complex conditions. It starts with cost, of course, the cost of these medications and how they are being handled, whether there are data and analytics to be utilized to support that, to provide us the ability to manage this. And again, making sure that those connections are happening with providers and from a comprehensive care perspective. That includes, as you see on this particular slide, pharmacy benefit management and the medical benefit management being tied together. The specialty pharmaceutical spend on the pharmacy side of the benefit is rapidly increasing for payers, and it is about to eclipse 50% of the total spend for most payers. And we're really looking at what we can do to address that, number one. But even more rapidly, we are seeing those increases where the specialty pharmaceuticals are reimbursed on the medical side of the business, and what we need to do about that as well in order to manage the drug spend for specialty there. In order to do that, combining those together into a holistic view of the benefit is truly important in order to assure that as the services are provided at the specialty pharmacy and infusion side of the business, that is occurring and that it's coordinated together. Looking at cross benefits, both pharmacy and medical, because as we know, on the pharmacy side, the technology that exists in order to adjudicate claims and have real-time responses of benefits and whether the product is covered, whether there are prior authorizations that might be required or step therapy, or whether there are networks of pharmacies and providers that are able to dispense those medications. That is very automated, and there is significant technology behind that. On the medical side, however, it's sometimes much more difficult to get that data, whether it's real time or even after the fact, in order to analyze where the specialty pharmacy spend is and what we are doing in order to address those concerns. By tying this together, by looking at the data holistically on both sides, and using analytics then to determine where we could apply this expertise that we have, is critical in order to assure that we are doing everything that we can for payers, for patients, and to ease the burden on providers in providing the care. Holistic cost management then incorporates all of these strategies that you see in front of you, whether that is from the benefit design perspective of which drugs are handled on a formulary, which drugs are rebatable or not, whether there are generic drugs, and whether we are going to have a brand versus generic strategy from the standpoint of the payer. Looking at which drugs we want to have that are most effective, and from a utilization perspective, is one drug preferred over another in a class, and those drugs must be utilized first in order to step the patient into the more expensive or higher cost therapies. Additionally, from a site of care perspective, we know that whenever patients are receiving these medications, especially infusions at a hospital or an outpatient setting, that the costs for these medications can be much higher than they are if they are provided within a physician's office, an ambulatory infusion center, or even at home via a home infusion provider. Additionally, on the right, there are other strategies that can be utilized. We are seeing more and more biosimilars coming to market and actually being available. For the most part, those therapies have been restricted to the medical side of the benefit, but we are starting to see more drugs coming to market on the biosimilar side, on the pharmacy side of the benefit. So understanding where the biosimilars make sense what that impact might be on rebates, what that impact might be from the standpoint of the total cost for a given payer is really critical. Copay cards and copay solutions has also been a topic that many of us have been involved with, helping patients, of course, afford their copays and afford the therapies, but also working with payers so that the payer can take advantage of where there's opportunity for patients to have access, but also for the payer to factor that into their plans with how they are going to administer these copay cards and have allowables for patients. We also look at risk management options. There's been a lot of discussion in the industry about value-based contracts and where we can work with pharma and we can work with payers in order to assure that the drugs that are very costly are actually being effective, and where there can be risk shared between the pharmaceutical manufacturer for the product that they are developing and from the payer's perspective, who is ultimately the one paying for that medication. When I spoke about the site of care, there's also the ability to take a look on the medical benefit and look at whether we want to move that from a reimbursement perspective over to a redirection program where we are moving that into a lower cost site of care. So where we see on the medical benefit most specialty products reimbursed, a large part of that is still sitting in the hospital outpatient system. So the ability to move that more towards the specialty pharmacy and infusion space or the physician's office will dramatically reduce a payer's cost profile for these drugs without impact to the patient. We'll be able to lower costs by almost half, and additionally save money for the patient by moving to a lower cost, which many times means lower copays and deductibles for the patient on the medical side of the business. Within Optum, for instance, we have a specialty medical guidance program which allows us to work with providers to get the patient onto the right medication at the very beginning from the medical benefit perspective. On the pharmacy side, it's much easier for us to get the patient to the formulary product or to step them through a specific therapy or to have a prior authorization. And on the medical side, we have not had that luxury with technology over the past several years. What we have been able to develop is a similar workload or workflow tool, as well as an algorithm for providers to utilize via this medical guidance program in order to have a provider log in, select the medication that they're looking for the patient to receive based upon the diagnosis, and have them guided through the most cost-effective, the most evidence-based and outcomes-oriented product. And I'll have all of that supported by data and analytics in order to assure that the patient doesn't have delays, that the patient ultimately is directed to a provider who is in network as well. All of this factors into lowering the cost for the provider in order to for the payer, as well as helping the provider reduce administrative burden as they go through their therapy selection. This was the slide I had at the very beginning that I started with, that essentially what we are looking to do then is, as we make all these decisions on the medical side, as we help patients go to the lowest cost site of care, as we have providers help select the product that is within that payer's formulary, and that we are getting them to the most evidence-based, outcomes-oriented therapy, is then deciding who is going to be the service provider. In many cases, this tends to be a specialty or home infusion pharmacist on the team who is then working with the provider to provide the care. But due to the many concerns that we typically have for patients, we are seeing that there needs to be a connection point across the patient's other providers and everyone else who is working with the patient to provide them for the products that they're receiving. So I have on this slide in particular an example of a disease state that is very expensive, and it is a chronic, lifelong genetic disease that patients are dealing with. So when you're diagnosed with hemophilia at birth, it is a genetic disease. It is passed down from the mother to the son, typically in hemophilia A or B, and primarily affects males. And what we have seen over time is a dramatic improvement in the treatment options that are available for patients. This is a particularly confusing and complicated disease state for many payers to understand, because over time, we not only have different ways for the patient to receive therapy, whether that is administered via oral, injectable, or infused manners, but also it crosses the benefits. So frequently, hemophilia products and therapies are reimbursed on the pharmacy side of the business as well as on the medical side of the business. So really understanding the disease state as a whole and cross-collaborating on pharmacy and medical in order to provide therapy to a patient is critical. Does the patient need to infuse the clotting product? Who's paying for the benefit? Is it covered on the medical side or on the pharmacy side? And then there are different cost profiles for each of the products in the different categories. So as you look from left to right, whether it is a non-injectable or non-infusable product to one that is infused, such as a clotting factor, or it is with new therapies that are out, like emicizumab, which is injectable, there are different costs that have to be considered to determine what is best for the patient based upon all the therapies that are now available. Last year, we had the first drug, which we were looking at coming to market in the gene therapy space. And we anticipate this year that there will be gene therapy for hemophilia. So how does that all factor into what we are doing in order to assure that patients are on the most effective therapy? But when we're looking at over $1 million for gene therapy for one infusion for a patient, how do we effectively select the patient, the therapy, and assure that there is a payment for that patient? Overall, specialty pharmacy is here to provide care to patients from a pharmacist perspective, of course, but also there are different ways for us as specialty pharmacists to impact the costs. Typically, this centers around the total cost of care. Because specialty pharmaceuticals are expensive, typically a lot of a patient's cost is driven by that specialty pharmaceutical. But we need to look at a total cost of care approach. What other therapies, hospitalizations, treatments is the patient receiving, including potential visits to emergency rooms? And what can we do to help avoid those additional costs that come about from having that disease? So whether that's care interventions, whether that's how we're managing the patient clinically, educating them, monitoring for side effects, optimizing their therapies, all of that matters from the standpoint of what we can reduce from a total cost of care perspective. You see that in oncology, you see that traditionally in transplant, but we're also looking at whenever therapies are not effective, if we can quickly determine that and discontinue the therapy, then we would save ongoing expenses for a payer by discontinuing therapies that are not achieving the outcomes we expect. It's really important to then think about, well, where are we going and what do we have coming up that can help us better manage these costs, whether that is on the pharmacy or the medical side of the benefit. And a lot of this will come about through better communication between providers, payers, and pharmacies. It also has to do with what else is coming out that will be available digitally or virtually. We saw a tremendous rush for people to move to telemedicine, telehealth, and to utilize digital and remote patient monitoring systems in order to communicate with their physicians, make sure that they were being adherent to therapy, and assuring that they were ultimately receiving the outcomes we all want if they're going to be taking expensive pharmaceuticals. What we're looking at is, how do we take this digital world that we have been thrust into even more quickly than where we were headed, and use this technology in order to help patients, help providers, and work with payers to determine what is most effective for a patient, what is most cost effective, and look at the patient from the standpoint as a whole and how we're going to manage the care across all areas. This involves looking at any of the specialty healthcare providers that are part of the care continuum for the patient, and making sure that we're drawing all of these connections across all of that. So lastly, what we have been working at Optum to do is see how we can leverage all of these and connect them. And we have some exciting tools that are available from the standpoint of managing the specialty spend on the medical side. We have many traditional tools that have been utilized very successfully on the pharmacy benefit. And by having a pharmacy and an infusion pharmacy as well that is connected into all of this data at Optum, we're able to draw all of this data together, provide better insights for payers, and then work better in order to help the patients receive the care that they need in a manner that is really what we're all looking to do, which is to take care of patients. So with that, I will turn it back to Amy. Thank you.
Thank you so much. Very, very insightful. We're going to hold questions for after Scott's presentation. So we'll transition over to Scott.
Thank you, Amy, and thank you everyone for the opportunity to speak to you this morning. My name is Scott Megill, and I'm President and CEO at Coriell Life Sciences. We are really focused on understanding why medications work and don't work for certain individuals, and how we can apply new technologies and tools to better target those treatment plans to the people that stand to benefit the most. It's a concern that's not only a health issue for patients, but also an economic issue for our payers and our systems that bear the burden of medications that aren't appropriately targeted. So fundamentally, we'd like to understand if a medication is going to be unsafe or ineffective for someone. It would be good to know that before we try it. And the standard of care for hundreds of years has been trial and error. Effectively, the physicians that are prescribing for individuals are following best practice guidance, but without full knowledge of the physiology of that patient, it's difficult to really know if that pill is being prescribed appropriately at the right dose for the right patient. So we really have focused on taking some learnings from all the way back to the Human Genome Project, and now decades of study around the effect between gene variation and medication outcomes, and putting that in the context of a more comprehensive medication review so that we can better target and provide more information, more clinical decision support guidance to physicians and pharmacists who are in the business of treating individual patients. So the big question is why? So why is it that some pills work for some people and don't work for others? And you'd be hard pressed not to have some experience of that either in your own life or someone in your family or friends. But certainly taking the same pill at the same dose can be dramatically different for different people. A lot of that can be traced now to variances in the individual's own DNA. So DNA controls for many drugs the pace at which that drug moves through the system, the pace at which it's metabolized. And so that can be a predictor for whether that person is going to have a positive outcome, a negative outcome, or one that's beneficial at all from a therapeutic perspective. The same drug, same dose, same diagnosis taken by two different people can really be variable in many reasons, or for many reasons, but DNA can be one of those reasons. That's now an emerging science that has gained tremendous traction with the FDA and other guidance bodies. FDA now prints pharmacogenomic, which is the science of this, the pharmacogenomic guidance on nearly 200 drug labels, and has now published their own findings for the evidence between association of gene variation and drug outcomes, predicted drug outcomes. So what's really lagging here is how do we target the right individuals to be able to utilize this information among lots of other vectors of decision support, and how do we get that actually implemented within the healthcare system? And that really has been our focus, and happy to sort of walk you through some of our experiences this morning. So the problem is a big one. 82% of Americans take at least one medication. I think the proliferation of statins over the last couple of decades has really increased the just sheer number of people that are on some chronic medication. It's the fourth leading cause of death in the US is adverse drug reactions and improper utilization of medications. Again, as published by FDA. FDA also says that about half of the drugs that people take don't actually help their care. Now, it's whether or not the drug is ineffective or the drug itself is just simply inappropriate for that person. About 50% of the drugs are just not hitting the mark. Significant cost to the healthcare system when we prescribe medications that are ill-suited for that person. It's not only the hospital systems that are bearing the burden of these additional hospitalizations, but of course it's the payers, it's the self-insured employers, anyone who's ultimately on the hook for an individual who has a poor reaction to an inappropriate medication. Those are obviously stressing our system in a way that is certainly not something that we all like. But the pharmacogenomic information is not a silver bullet. You could think of it almost like an allergy test. So I personally, I am an ultra rapid metabolizer on a gene called CYP2C19. This is nothing I would have known by just going to a standard doctor's visit, but having had a pharmacogenomic test, I know that now that there are certain medications, including some of the most widely prescribed blood thinners, just simply won't work for me. So that's not something that's immediately important to my care because I'm not on a blood thinner, thankfully. But knowing this, like allergy information, knowing this for my future medical care is extremely important and something that I find very valuable. Had I been on Plavix, had I been on a blood thinner that was impacted by my particular genetic variation, that would have caused an immediate recommendation change to another drug which would be more effective for me. So that really is what we're looking to do, is sort of tune this in the context of an overall treatment plan such that we're taking into account drug interactions with each other on kind of a chemical level, those genetic variation interactions, lifestyle interactions, interactions with the basic demographics of the individual. So if someone is elderly and there's potential toxicity concerns, we want to bring all of that information to bear at the time in which we do a comprehensive review of what's really right for this patient, genetic and non-genetic guidance. But more importantly, we have to be able to measure the impact of a program that utilizes comprehensive medication management services empowered by pharmacogenomics. And that really requires that we understand who's the population first. So doing that analytics work, understanding where the hotspots of opportunity are, how do we target those individuals that would gain the most benefit for their own health and from an economic standpoint for the system. How do we engage those members in a way that is not seen as in any way threatening to their privacy or to their health? And how do we then get them to ultimately submit a genetic test, right? And so this is something that we've worked very, very hard to do and to hone a playbook to ensure that we are launching programs that are non-disruptive and really show value quickly. Ultimately, this culminates with a pharmacy review, and we really believe that pharmacists are the critical cog in this whole process. Nobody in our healthcare system is better positioned to be able to provide that coordinator and quarterbacking role across an entire treatment plan than pharmacists. The unfortunate reality is most pharmacists are not practicing at the top of their license based on the systems and the constraints that they have. This really gives pharmacists a way to flex the muscles that they've honed through their education and their experience and be more directly related to the care of patients. So it's been a really lovely model to roll out and one that has really shown a lot of value. Just want to give a little examples here on some of the actual outcomes and benefits. So the process that we really advocate for is one that, again, starts with that comprehensive targeting. So how do we ensure that this is really an intervention that's appropriate for certain individuals within a population? And we find that, there are sick people in every population. So an apparently healthy population of employees could be, quite young, skewing demographically. You're still going to have a percentage of those individuals that are high utilizers of the healthcare system for whatever that concern is. On the other end of the spectrum, if you were to look at a senior population, pension funds, ACOs, where 65 plus is the norm, there's going to be a higher percentage of people who are appropriate, but there's still, the outcomes are very, very similar for those individuals. So what we really advocate for, again, is the targeting of individuals that can make the best use of this kind of information at the moment. So this isn't really about, let's give you that allergy list for the rest of your life, though that's exactly what one of the outcomes of this is. This is about how can we make real change today that is impactful for the individual and for the system. So from there, it's that outreach and engagement through education, through assurance that this is something that really is being targeted to help you and your health and your physician make better choices for you. That sample processing now, the really nice thing about this technology is it is incredibly mature. So Human Genome Project finished in 2003, several $1 trillion in order to complete that first human genome. Now we can sequence the appropriate parts of the genome that are hypervariable for medication response for tens of dollars. So we went from billions to tens of dollars. So really an amazing progression in technology and maturity there. And then, of course, that pharmacy review using trained pharmacists who have been both engaged in the science of pharmacogenomics, but also in how they can counsel their patients and then ultimately convey an action plan, a clinically useful, immediately relevant action plan back to their treating physician, back to the patient's own doctor. And then how do we measure that over time? So how do we understand where we are at the start of the program? How do we know that the benefits that we're seeing are because of this program? And then ultimately, what is the dollar value in ensuring that individuals are actually cared for in this way? So that population analysis usually starts with looking at pharmacy utilization. So what drugs are being used by which individuals within the population, and what have their healthcare needs been? And that's typically a look at claims information. So that's a retroactive look at usually 12 months of claims to see who are our high utilizers of the system, who are on drugs that we know to have pharmacogenomic implications. That doesn't mean that everyone who could potentially have an issue with genetics has it. But when you take a drug like Plavix, I'm one of about a third of the world's population that has trouble with Plavix because of my genetics. So if you have 1,000 people in your population that take Plavix, you can bet around a third of them actually are getting no benefit from it whatsoever. That money is being ill spent and that patient is not getting the therapeutic intent. So using that kind of overlay information, we can make some predictive models on what the return on the investment would be to pursue a program like this, and then ultimately target those individuals for education and outreach and encourage them to go through the process of genetic testing and pharmacy review. That's really done with a series of outreach and communications electronically or more traditionally, mailers, telephone calls, whatever is appropriate for getting in touch with that population. We very often will work through pharmacy benefit management groups. It was great to see Michael from Optum, one of our partners, and we're just launching now this sort of service with Optum as well. But this is about really getting them engaged, enrolled, and then getting a DNA test kit out to them. Typically, this is done right to their home, saliva kit that they can perform just like an Ancestry.com or a 23andMe kit, though this is a clinical test. This is not a direct-to-consumer, non-clinical test. But that DNA sample then makes its way back to one of our laboratories, where it's then tested and then brought into a clinical decision support tool that's used by our pharmacy teams. So this is really the secret sauce of it, because there's so much information that needs to be brought together from the FDA, the CDC, the AMA, from pharmacogenomic consortiums, All of this has to be brought together into a decision support tool that gives those pharmacists a really fast and easy way to see which drugs are really wrong for this person, and more importantly, which alternatives on the market would be better suited for them. So it's testing all of those in a kind of a real-time modeling to see what drug is actually going to be better tuned for this individual so that we avoid all of those other potential complications, genetic and non-genetic complications. The result of that is a medication action plan, which is then delivered back to the patient's own doctor so that they have a really short and concise way of seeing what's the recommendation from this pharmacist that's done this review. We recommend you go off of this pill onto this one for this patient, and here's the reasons why. So it's very straightforward and really intended for an uninitiated physician, one who does not have to be a geneticist, only has to know that there has been an experienced, learned intermediary pharmacist that has done this comprehensive review. Then ultimately, it's about measuring this. So how do we understand what the health outcomes are through reduction in cost, reduction in utilization, improvement of quality of life, all of which we do through ongoing claims analysis, ongoing contact with our patients to hear how they feel about the process, any impact that they've had in their health, and then of course engaging those physicians where we can to ensure that they also buy into the fact that this review is valuable for helping to steer their care. A little bit of a case study. So we began working with the teachers' retirement systems in the state of Kentucky about 3 years ago. 36,000 retirees aged from 65 all the way up to 109. They have two lovely ladies who are 109 and still hanging on. We went through this whole process with them at the early stages, identifying those individuals who would be most appropriate, outreach and enrollment, which can be challenging in a senior population when we don't have as much of the technology channels as you might otherwise to be able to engage these individuals. But they were very receptive. These are educators by nature, retired teachers, and so there's a natural curiosity there that I think also helped drive some of that engagement. What they saw over the course of this program has been an average annualized savings of more than $5,000 per enrolled member because of largely cost avoidance. So this isn't about getting people on cheaper pills. This is about avoiding the hospitalization that would have occurred if they stayed on the wrong pills. This is about avoiding unnecessary laboratory tests, doctor's visits, things like mood disorder issues where we're going through a saga, a journey to get to the right dose of the right potential treatment that can be shortcut by doing some genetic testing and some comprehensive review ahead of time. So really significant cost savings for them, 11% reduction in pharmacy spend. But a lot of that was not, again, cost switching or drug switching to cheaper medications. It was the reduction in the number of pills. And we heard this over and over again that through this process, we learned that the particular statin that someone was taking was causing joint pain. And so because of that joint pain, they were also on an anti-inflammatory and a pain management medication. Well, if we got them on the right statin in the first place, we can eliminate the need for that anti-inflammatory or that pain med, thus reducing the overall pharmacy spend. So that really was the story that emerged there. More importantly, 22% reduction in hospitalizations, 27% reduction in slip and falls, which of course is an acute issue in these senior populations. But really all the metrics moved in the right direction, all of which really validated for Kentucky that this is a program that they want to continue to renew year over year for all of their members. And with that, I'll go ahead and end and say thank you and happy to take any questions.
Great, thank you so much. Before we start into questions, I really do want to thank both Mike and Scott for presenting at our conference today. So we're going to move to some questions, which we've actually gotten some in the chat box. And so I'm just going to kick it off with one of our first questions, which is there any impact on patient outcomes if patients are getting medications through patient assistance plans and the claim is not adjudicated on a medical or pharmacy plan?
So I'll be happy to take that one, Amy. So
Sounds great.
There are a number of patient assistance programs out there, so it could get a little confusing. So let me bucket them at least. So there are patient assistance programs where pharmaceutical companies provide compassionate or free drug for patients that don't have any coverage. And when they do that, that does not go through any adjudication or insurance plan, obviously, because the patient doesn't have coverage. There are also copay cards, and anytime a copay card from a manufacturer is used, that goes through a specialty pharmacy or a pharmacy if it's not a specialty pharmacy. And we have the ability in our systems to track that patient receiving the medication. And many times those copay cards go through adjudication engines. So there's a lot of data and analytics that come about from that. There are then patient assistance foundations. So these are for patients that don't qualify for a copay cards. Government programs, for instance, cannot use copay cards, but they can use patient assistance foundations. And most of the foundations now also have the ability to adjudicate claims so that we could capture that data in our pharmacy systems, even if they're not going through a payer. And the reason I bring this up is because it's really important to understand how the patient is going through the process. So if they are getting free drug from the manufacturer, it's not typically going through a pharmacy or a payer system, and we may lose sight at that point of the patient on that therapy. They essentially disappear from the system because they're off into another area. That doesn't mean, though, in any of these cases that the patient's outcomes may be impacted. What that means is we may have blank spots or holes in the data if we can't see the patient holistically as they're moving across different assistance types. So it doesn't happen very often, but it is something to be aware of, that as patients move on and off free drug from a pharmaceutical company to adjudicated claims or medical claims in a payer system, that we may have some data not available that makes it look like the outcomes are not being achieved, or that the patient's not being adherent to a therapy or being treated at all. So those are things just to be knowledgeable about. The wonderful thing is that if the pharmacy is part of a payer like a PBM or a medical plan, we're able to combine the data that's in one system with the data in a payer system and get a holistic longitudinal view of the patient's data over time to look and track those outcomes. So hopefully that answered the question.
Yeah, so it sounds like better communications overall is important for the appropriate use of medications, especially specialty RX.
Exactly.
How do specialty pharmacy providers integrate or share data in between pharmacy and medical? And if both Mike and Scott could address that, given that you included a little bit of that in both of your conversations this morning.
Sure. Do you want me to take it first, Scott, or do you want to go first?
Please.
All right. So the good part about a pharmacy, a specialty pharmacy, is that we have a pharmacy operating system that all the prescriptions for a patient are contained in. So whether we are billing the pharmacy side of the benefit through the adjudication platform for a PBM, or we are providing claim data and billing the medical side, it all looks the same in the patient's profile. We're able to provide that data at the pharmacy level back to the PBM, back to the medical plan. We're even able to combine it and provide it back to both in a consolidated manner, so that regardless of where the patient is having their medications billed, that the data can be shared back in a very clear way, so that the payers, the insurance companies, the PBMs, can ultimately see everything that's going on for that patient across both benefits. Additionally, if the patient is receiving a specialty pharmaceutical that is not going through the specialty pharmacy, maybe it's going through a retail pharmacy because it's available at retail, maybe it is being infused in a doctor's office or a hospital, the ability to take a data file from the medical side, a data file from the PBM side, any additional data from the pharmacy, and combine all three data sources is really the beauty of being able to work together across all of those platforms to connect the patient's care.
Thank you. Scott?
Yeah, I'll just add to that. This is why we love working with partners like Optum, because these systems are already integrated, end to end. When we're dealing in scenarios where we don't have an integrated healthcare system or a unified cover from a technology perspective, like a pension fund. So in Kentucky, the physicians that are actually in the receipt of these recommendations are not connected with a unified electronic healthcare system. They're not actually receiving the information from a unified prescription system. And so what we have to do to cover that gap, which is really a gap in the US healthcare system, is we have to do actual outreach to those physicians from our pharmacists in whatever way they can receive the information. So where we have clusters of patients and we can integrate with a healthcare system, we do. So we have lots of integrations with Epic and Cerner and Siemens and Allscripts. But in many cases, it means now, even today, still faxing things to a physician's office or picking up the phone. But because these are point-in-time recommendations, what we're mostly interested in is conveying the recommendation and then reviewing the actual results through claims analysis later. So did they actually make the recommended change? That's more of interest to us than making sure that they have an electronic version of that recommendation. So basically, the end result is we work with whatever's available, but it's not always easy. It's not always easy.
Yeah. It doesn't sound like it complicated, but important communication, right? I think you both
You got it.
have emphasized that. So we did receive a question on how do pharmacogenomics identify that 50% of drugs, the 50% of drugs that are not working. And a follow-up to that was, how can we use those to help in mental health?
Sure. So the statistic out of the FDA that 50% of drugs are really ineffective at helping your care is a little bit separate from the pharmacogenomics side. So gene variation, drug by drug, the prevalence of variants that would cause a drug not to work or to be unsafe for someone varies widely among populations. And a lot of this has to do with ethnicity. So I mentioned when I was speaking earlier that a third of the population, a general US Caucasian, mostly population, about a third of the population won't be able to metabolize Plavix. Well, it's about 50% in Pacific Islanders and Asian populations because that gene variant is more prevalent in that particular ethnicity. So it's highly variable depending on the drug and the ethnic background of that individual. Because ethnicity is really just a proxy for genetics, or genetics is a proxy for ethnicity. So it's really about what was passed down from parent to child that continues to be a variant that's impactful for drugs. That said, so we don't have a magic test that says which of my 10 drugs are working and not working, which half are working and not working. It's going to be different based on the drugs and the person, right? So it's really, it's kind of two different statistics. On the mood disorder side, this is actually one of the most widely and deeply studied areas of pharmacogenomics, is in mood disorders. The impact of genetic variation on depression, anxiety, ADHD medications, all of that has actually been well-trodden ground and can really help to shorten that path to what is the appropriate therapy for an individual, because there are ones that we can avoid, right? That's really the goal of this, is let's go down paths where we don't have a genetic concern that might cause a therapy to be inappropriate. So this is actually an area that was one of the first to be reimbursed by Medicare. It's been adopted pretty widely among the payers for reimbursement for the genetic test itself. The VA has started using pharmacogenomics for mood disorder, PTSD treatments, things like that. So that is an area where there's a lot of well-trodden ground there for mood disorder and pharmacogenomics.
Thank you very much. We had a lot of discussions today about pharmacogenomics and pharmacogenetics, which thank you, Scott, for allowing me to use the simpler version of that. Are there resources that employers can look to on this topic if they want to learn more?
Yeah, there are a number of consortiums that are really focused on exactly this. There's a great group called Get the Meds Right, which is the GTMRX organization. They are really focused on helping to implement comprehensive medication management services. You can always call us, right? We're happy to advise in this case as well. But there's also the precision medicine action groups. There's a large number. Focused purely on pharmacogenomics is CPIC, which is the Clinical Pharmacogenomics Implementation Consortium. And that's a group of largely academics that have really been charged with identifying the evidence between gene variation and medication outcomes. But if the question is about how could we actually explore a program like this, the Get the Meds Right group, or certainly us, we can point you in the right direction. But of course, we're a little biased. We'd love to have you, we'd love to talk to you about implementing.
Sure. Thank you so much. We had a question come up in the chat box, which I apologize. I'm going to look over to my other system here. These integrated systems go well beyond the efforts to have any regional national database for health information providers can share. Because of that deficiency in sharing data, the specialty pharmacy market needs these partnerships in sharing data, ? All while PHI needs to remain protected. Thoughts, Mike?
I'm listening to the question, and if I don't answer it right, let me know, because I'm trying to process it. I think it's vitally important. So I'll tell you a little bit about what we have set up in order to share data. We are able to, as Scott said, connect with various EHRs, electronic health records that physicians, hospitals are using. And we now have the ability to share data two ways. We can go into the EHR, look at data specific to a patient, and we are able to pull information that is clinical so that we can minimize the faxing of information back and forth, or requesting information whenever we could just simply go and obtain it through the EHR ourselves. So we've been successful in being able to connect and go in and have data come to us. But most recently, we've been able as well to take our data and then have it get pushed back into certain EHR systems. There are a lot of them out there. It is not a simple thing to do a connection and have that work and have the information shared freely. But there's been a lot of progress lately, especially in the advent of all the COVID that has happened, for a lot of connections and technology to be used so that we can do a much better job of sharing this information and connecting. Are we where we want to be, where regionally, nationally, there's a single database of information clinically on a patient that no matter who the provider is can go in and use? No, not yet. I know there are privacy concerns about that. You mentioned PHI, where we don't want anyone to just be able to go in and look at somebody's PHI. So I think that in looking at security and privacy in combination with ease of sharing the data, so that every time I go to a different doctor, I don't have to fill out yet another form of my history and everything that's gone on with me. I could simply say, hey, connect here, and here's my history, and you could see everything that's happened to me, so that you could do a much better job, doctor, in providing care to me.
Yeah, thank you. And Scott, if you have anything to add to that?
Yeah, well, I couldn't agree with Mike more. I think, the unfortunate reality is we can't get everybody to agree to wear masks, let alone share genetic data. So I think it's absolutely going to be driven by patient portability of information. Your health record will ultimately be accessible or carried around with you on your phone. I think it's, Eric Topol had a great book a few years ago, The Patient Will See You Now. And it was really about sort of the democratization of healthcare and healthcare data, and pushing all of that to the consumer rather than to the healthcare system at large. And I think that really is he's a bit forward thinking in that.
Well, you were asking if you got the question right, and you just got a big home run from the participants on the line. So once again, I'd like to thank both Mike and Scott for presenting today. This was incredibly informative, and we'd really like to thank Fitbit for sponsoring this session.
Great,
thank you.
Absolutely. So I did put in the chat box for those who are online what the session code is for today. We have already launched the poll for SHRM, HRCI, and ODI credits. If you'd like to receive the credit, simply click on the tab entitled Poll on the screen. It's at the right-hand side, and answer the question. So we'd encourage you, hang on one second, just move this forward here. There we go. We'd encourage you to visit our virtual exhibit hall throughout the afternoon. I did mention during Florian's introduction, we have a few leaders today, but it's a fierce competition at the top. So I encourage you to get out there. The next live exhibit hall hours are between 1:15 and 1:45 p.m. 1:15 and 1:45 p.m. To participate in this year's event challenge, simply visit or meet with one of our sponsors in the virtual exhibit hall. Every time you interact with a sponsor, you'll get a code, a unique code from them to punch actually into the event challenge game. And as attendees accumulate the most points over the 5 weeks, you'll get a chance to win a Fitbit Charge 4 prize packages. So then you'll be ready to participate in our spring Step It Up challenge starting March 14th. And so I did mention the conference code. So 8SB, that's 8SB. After this 5-week challenge, the participants with the highest number of points will win a Fitbit Charge 4 prize package. And then is evaluations. You know, we can't do this without getting feedback. It is really, really important. And so I encourage you to please complete the evaluation form, and you'll also be entered into a drawing to win a $50 Dick's Sporting Goods gift card. The evaluation is found inside the agenda at the bottom of this session under links. Please join us for one of our 2 roundtable discussions. One is a continuation of this topic on specialty pharmacy and on reboarding employees, sponsored by Modern Health and the Business Solver. So those both start at 4:30 p.m. Eastern Standard Time. And as an extra incentive to join our roundtable discussions this afternoon, one individual in each roundtable will actually receive a door prize. Now, the winner will be announced during next week's conference, but in roundtable 1, attendees could receive a pair of Powerbeats Pro provided by Quantum Health, and participants in roundtable 2 have a chance to receive a Comfort and Joy travel gift set provided by Optum RX. So thank you very much again to our presenters and to Fitbit, our sponsor for today's session, and we'll look forward to seeing you all at 4:30 this afternoon.